I welcome all of you on behalf of WBACTVA to attend this CME. And after a long time, we are meeting again, and the program will now will be one after another. CME and other programs will be there. I request our scientific secretary, Dr. Somidas, to start our program for today. Somi, we are not able to hear you.
Hello.
Yeah, am I audible now?
Yes.
Yeah, am I audible?
Yes, you are audible now.
Yeah, okay. Thank you, Dr. Verma, and welcome all to today's program, scientific program organized by WBACTVA. And we yet again meet on a virtual platform given the corona status. So the topic for today, without much ado, let us begin the scientific program. The first topic is neuroprotection and the aortic surgery, a very intriguing topic given the various neurological problems we get in surgeries for the on the aorta. So the topic will be delivered by Dr. CHANDAN MONDAL. He is a senior consultant in RN Tagore Hospital in the cardiac anesthesia department. And over to Dr. CHANDAN MONDAL to deliver the
Good afternoon, everybody. Today, our topic of discussion is the neuroprotection and aortic surgery. First of all, just I want to say that this aortic surgery and neuroprotection, it is a huge topic, and it covers both the ascending aorta, arch of aorta, descending aorta, and the abdominal aorta part. And so I just divided the whole thing into two. One is the first ascending aorta arch and the thoracic, and the second part is the abdominal aorta. So, before going to the just particular the neurological problem in aortic surgery, I just want to just say something about the general consideration for the aortosurgical patient, because it starts from the pre-surgical evaluation, pre-anesthetic evaluation, proper history, and today, nowadays, the point of medical issues is huge. So minute details of the patient's previous history is so important, because after the surgery, there could be a stroke, there could be a type 2 neurological dysfunction, various types of problems, or it could be something related to the spinal cord ischemia, the effect, paraplegia, paraparesis, and all these things. So prior taking the patient, neurological evaluation, proper history taking, details examination of the physical status of the patient is so important, and we need to get the sign of the patient party and the patient that we are going to do all these things, and we should discuss the whole thing to the patient and the patient party that we are going to do all these things, and these are the complications and all these things. So the urgency of the operation, particularly whether the surgery is emergent or urgent or elective, that should be discussed. The pathological and anatomical extent of the disease is very important, because that dictate the course of the surgery and the outcome. And also the involvement of the artery, involvement of the aorta, whether that has involved the arch or descending thoracic aorta or abdominal aorta, that will decide our surgical approach, whether the median sternotomy or through the thoracotomy approach, or nowadays the endovascular approach. And also from anesthesiologist point of view, we should also consider the mediastinal mass effect due to this huge dilatation of the aorta, or ascending aorta, or descending thoracic aorta, and that there could be a possibility of the aortic compression or deviation. So all these things should be kept in mind. So pre-existing or associated medical conditions that can lead to a post-operative neurological dysfunction, there are lots of problems. There could be lots of problems. But we should, in this discussion, we should consider only the neurological point of view, neurological problems. That is the previous history of aortic valve disease, aortic tamponade, coronary artery disease, cardiomyopathy, particularly the cerebrovascular disease. Minute details of the problem should be addressed. And also the preoperative medication of the patient, whether the patient was taking any warfarin or any antiplatelet therapy or any antihypertensive drugs, because in the previous slides we will discuss that to maintain the spinal cord perfusion pressure, we need to augment the pressure. So before all the hypertensive drugs, because we should stop the ARB or the AC inhibitors to maintain the blood pressure and all these things that are all important. So anesthetic management, we should, from the monitoring point of view, we should monitor the hemodynamic monitoring, proximal aortic pressure, right plus minus left radial pressure. Every radial pressure, either right or left, they have the separate indication whether we should only monitor the right or only monitor the left or both. And also the distal aortic pressure, like the femoral artery pressure, and we should also monitor the central venous pressure, PA pressure, and cardiac output monitoring, and obviously the transesophageal echocardiography. So neurophysiologic monitoring, see, theoretically we should monitor all these things like EEG, somatosensory evok potential, motor evok potential, jugular venous oxygen saturation, lumbar cerebrospinal fluid pressure. Normally we do that lumbar cerebrospinal fluid pressure, body temperature, both core and periphery, because in the due course of rearming that the difference of these two temperatures is very important. And also the near infrared spectroscopy NIRS. So though the role of this NIRS is very controversial, some people are saying that this NIRS does not reflect the true oxygenation of the cerebral hemisphere. Some studies are showing that it's okay. At least it will give some broad idea about the cerebral oxygenation. So these are the available neurophysiological monitoring. But from in our institution, from day-to-day life, during this complicated surgery, we normally monitor that NIRS and the body temperature, and obviously the lumbar cerebral fluid pressure. So the mode of ventilation during the aortic surgery, that sometimes we need the double lumen endotracheal tube and or the endobronchial blocker. Potential for the bleeding, what are the max A points? Large bore intravenous access should be there. Blood product available, there should be available. Antifumarate therapy and antibiotic prophylaxis should be taken care of. So postoperative care consideration and the complication. There could be hypothermia, hypotension or hypertension, bleeding, spinal cord ischemia, that is very important from our point of view, from our today's point from the discussion, stroke. Then there are lots of things: renal insufficiency, respiratory insufficiency, phrenic nerve injury, diaphragmatic dysfunction, recurrent nerve injury, or pain management. So thoraco-aortic aneurysm surgery, why the temporary interruption of the cerebral blood flow? Definitely there will be a temporary interruption. So what are the problems? What are our concerns in this surgery? First is the stroke. So what are the mechanism of the stroke in this aortic surgery? First is the cerebral ischemia due to hypoperfusion or temporary circulatory arrest. Definitely we are going to do the DHCA or MHCA. Or cerebral ischemia due to embolization secondary to CPB or atheroma. So the arterial emboli, it could be air, or it could be a particulate due to several products. So arterial emboli due to air introduced in the circulation from the open cardiac chamber, vascular cannulation site, or arterial anastomosis. And atherosclerotic particulate that dislodge during the surgery, during the clamping or declamping time, creation of the anastomosis in the ascending aorta or aortic arch, or excision of the severely calcified valve. And also there are some complication due to the CPB, particularly the microparticulate aggregate of platelet and fat. And the turbulent high velocity blood flow may dislodge atherosclerotic debris. And there could be a problem due to retrograde blood flow through the disease DTA, distal thoracic aorta. So what are the neuroprotective strategies? First is the deep hypothermic circulatory arrest. Second is the topical cerebral cooling, controversial. Retrograde cerebral perfusion, not used very much in nowadays. Selective antegrade cerebral perfusion, very important. And cerebral hypothermia, cerebral hyperthermia prevention during the rewarming. So first, coming to the deep hypothermic circulatory arrest. Why it is so important? Now, the first thing is the brain is very susceptible to the ischemic injury due to the high metabolic rate, continuous requirement for the metabolic substrate, and limited reserve of high energy phosphate. That's why brain is so susceptible to ischemia or hypoperfusion. Now, physiological basis of this DHA is to decrease the cerebral metabolic rate and oxygen demand. Now, evidence also says the autoregulation of the cerebral blood flow is maintained during the DHA with the alpha state blood gas management without compromise of the clinical outcome. So now it is very astonishing that there is no optimal protocol for this conduct of deliberate hypothermia. So normally what is the normal practice, that average nasopharyngeal temperature, which is the core temperature for DHA, is about 18 degrees centigrade. But the question is why it is 18 degree, why it is not 17 or 16 or 12 or not 20 degree, why it is defined at this 18 degree. Now, the main problem is that we are unable to measure the direct brain temperature. And for that reason, what are the options we have? First, the EEG or the jugular valve venous oxygen saturation. And it has been seen that DHA alone, it is the excellent neurological outcome. It gives an excellent neurological outcome. And the technique of DHA alone is a reasonable approach for neuroprotection during aortic arch surgery in the setting of adequate institutional experience. It is very important. Now it is a class 2A recommendation, level of evidence B. Role of topical cooling is controversial. No benefit, or some say that there is a potential harm in this topical cooling, and it also interferes with the EEG or cerebral oxygen monitor, and it is also an institutional practice. Now, DHA extends. What is the benefit of this DHA? It extends the CPB duration with consequent risk for coagulopathy and embolization. You know, there are three components. One is the DHA, another is the DHA with antegrade cerebral perfusion, whether it's selective, it could be the selective ACP to be unilateral or bilateral. And another nowadays, which is coming nowadays, is the medium hypothermic circulatory arrest with ACP. So initially the people started doing this only the DHA. That and what is the benefit of the DHA? It extends the CPB duration, but you cannot prolong the CPB duration for a long time because there is a problem with the coagulopathy and the embolization. So rewarming also can aggravate this neuronal injury, and to maintain a temperature difference not more than 10 degrees between the heat exchanger and core temperature during the rewarming time. And also we should monitor the temperature between the core temperature and the peripheral temperature that should not exceed 3 degrees centigrade. And we should also avoid the cerebral hypothermia, that is nasovision temperature more than 37.5 degrees. That is a class 3 recommendation, level of evidence B. Now, along with this DHA, there are two options. This one is retrograde cerebral perfusion, another is the antegrade cerebral perfusion. First, we will discuss the retrograde cerebral perfusion. This cerebral perfusion technique performed by the infusing cold oxygenated blood into the SBC cannula at 8 to 14 degrees centigrade via CPB. I have not given any this diagram because to explain this diagram it is a time-consuming thing. So that's why I just omitted that's the whole circuit. IGB pressure maintained at less than 25 millimeter Hg to prevent the cerebral edema. And this IGB pressure is measured from the introducer part of the IGB catheter at a site proximal to the SBC cannula and zeroed at the level of ear. And patient position should be 10 degree Tenderbrug to decrease the risk of cerebral ear embolism and to prevent the trapping of air in cerebral circulation. Now, the Rcp flow rate should be 200 to 600 ml per minute. Potential benefit of the Rcp, what are the partial supply of the cerebral metabolic substrate, embolic washout, and maintenance of the cerebral hypothermia. Still, it is not a standard technique for neuroprotection in DHCA. So there is a balance between DHCA with Rcp versus moderate hypothermia with ACP. Lots of debate which path we should take, which is a better modality. But nowadays, people are going more towards the moderate hypothermia with ACP. Now, selective antegrade cerebral perfusion. It is considered for the aortic arch repair longer than 45 minutes, and DHCA with selective ACP is superior to DHCA alone. It is very important because nowadays, normally, when there is a arch, all the arch vessels are involved, we go for the this DHCA with the antegrade cerebral perfusion. Now, how it is done? The selective cannulation of the right axillary artery or right subclavian artery or brachiocephalic artery or left common carotid artery is done, and or inserting an individual perfusion cannula into the open end of the aortic branch vessel after opening the aortic arch. So after opening the aortic arch, they put a separate cannula in the left common carotid, the separate cannula in the left subclavian. And also definitely initially they have also definitely they put in the either in the axillary artery or in the subclavian artery or the brachiocephalic artery. And the oxygenated blood at 10 to 14 degree at a flow in the range of 250 to 1000 ml per minute to achieve a cerebral perfusion pressure of 50 to 80 millimeter of mercury, because this cerebral perfusion pressure we should monitor in the right radial artery. Now, unilateral or bilateral ACP. So unilateral ACP, it is via the right axillary artery. It is very common. Assumes an adequate cycle of Willis. We are assuming, note that. And anatomic completeness of the cycle of Willis does not guarantee cerebral perfusion. Now, what the surgeon does after when they go for this unilateral ACP, they first start giving this cerebral perfusion through the either through the brachiocephalic or the or the right axillary artery. Now they clamp the brachiocephalic, they clamp the left common carotid, and also clamp the left subclavian. Now, after giving this perfusion, they just declamp the clamp in the left common carotid. If the flow from the left common carotid is adequate, they assume, note, they assume the cycle of Willis is intact. So sometimes they give only the unilateral ACP. The point is, anatomic completeness of the cycle of Willis does not guarantee a cerebral cross perfusion. So to be in a safer side, we should preferably give bilateral antegrade cerebral perfusion. And it is essential to monitor the contralateral hemisphere with the cerebral oximetry, carotid artery scanning, or transcranial Doppler. Now, which ACP is superior, unilateral or bilateral? Study says stroke rate similar, but the period of safe ACP is prolonged in the bilateral ACP. And the recent meta-analysis demonstrated in aortic arch reconstruction both achieve a similar outcome for perioperative mortality, stroke, and delirium. So from complication point of view, both showing the same result. Now, there is another point, DHCA with the ACP versus MAC, that is moderate hypothermic circulatory arrest with the ACP. MAC with the selective ACP appears to be an adequate technique for adult aortic repair, aortic arch repair. Safety is limited in the setting of the elderly, multiple comorbidities, and extended operation time. And overall, DHCA with the ACP is reasonable in the setting of adequate institutional experience. Now, what are the pharmacological neuroprotection strategies for the DHCA? There is no proven pharmacological regimes. What are the agents normally people use? Fentanyl, we use thiopentol, propofol, steroid, magnesium sulfate, and lignocaine. And that should be considered as the neuroprotective adjunct, not the substitute for the hypothermia. And DHCA with the pharmacological adjuncts is reasonable approach. It is a class 2A recommendation, level of evidence B. Now, coming to the next part, the descending thoracic and thoracoabdominal aortic aneurysm. We know the proper classification of thoracoabdominal aortic aneurysm. Clinical outcome of the TA repair operative mortality is very high, permanent spinal cord deficit, stroke, acute renal dysfunction, cardiac complication, pulmonary complication, bleeding, reopening, re-exploration. So now mortality and the paraplegia after the thoracoabdominal aortic aneurysm repair from a neuro complication point of view, TA extend 1, 2, 3, 4. Now see the operative mortality is 6.7% in case of TA extend 1, in 2 9.1, in 3 12.7, and 4 5.7. But the permanent paraplegia or permanent paraparesis, it is huge. Now descending thoracic and thoracoabdominal aortic aneurysm, the operation, the mode of operation, I mean the operative surgery, the strategy could be different. The simple aortic cross-clamp technique, it totally depends upon the extent of the aneurysm, or they can use the goat stand or the partial left heart bypass, CPB with the DHCA, or the endovascular stent graft repair of thoracic aortic aneurysm. This is a new one, very popular nowadays. So simple aortic cross-clamp technique. Why I am giving this this picture and all these things just superficially, because all these things are related to the complication of the neurological complication. They put just to clamp just proximal and distal to the aneurysm. In the goat stand, they put a shunt from the proximal to the distal part, partial left heart bypass, and CPB with the DHCA, normal CPB with the DHCA. Now, why this distal perfusion is so necessary, and what is the potential advantage? Control of the postural hypertension, decrease the left ventricular afterload, less hemodynamic perturbation with aortic clamping and unclamping, decrease the duration of the mesenteric ischemia, decrease the risk of paraplegia, paraplegia from the spinal cord ischemia, very important. Ability to control the systemic temperature with heat exchanger, vascular access for rapid volume expansion, ability to oxygenate blood with extracorporeal oxygenator, and maintain the lower extremity SSAP and the MEP for the neurophysiological monitoring. I am not discussing the potential disadvantage. Now, anesthetic management of the thoracoabdominal aortic aneurysm repair, from neurological point of view, paraplegia after the TA repair, lumbar cerebrospinal fluid drainage, we should discuss arterial pressure augmentation, intraoperative neurophysiological monitoring, spinal cord hypothermia, and pharmacological protection of the spinal cord. So paraplegia after the thoracoabdominal aortic aneurysm repair, the factors which contribute to the paraplegia after this operation: thoracoabdominal aortic aneurysm extent, hypotension or cardiogenic shock before operation, emergency surgery, aortic rupture, presence of aortic dissection, duration of the aortic cross-clamp time. Obviously, more cross-clamp time, more ischemia to the spinal cord, and the chance of paraplegia is more. Sacrifice of the intercostal or segmental artery branches, prior thoracic or abdominal aortic aneurysm repair, prior repair of the type A aortic dissection, occlusive peripheral vascular disease, and anemia. Now, to minimize this paraplegic risks after thoracic or thoracoabdominal aortic dissection, minimize the aortic cross-clamp time is very important. Distal aortic perfusion should be maintained. Passive stand, that is like a goat, should be placed, or partial left heart bypass or partial cardiopulmonary bypass. The main motto is we have to maintain the distal perfusion. Or delivered hyperthermia, I'm not going in details. There are 3 categories: mild to moderate hypertension, systemic hypothermia, deep hypothermia, or selective spinal cord hypothermia. Increase the spinal cord perfusion pressure. We have to increase this SCPP. So reimplantation of the critical intercostal and segmental arterial branches. You know, in our setting, my experiments to reimplantation of these critical intercostal and segmental arterial branches are very limited. But normally we do the lumbar CSF drainage when the CSF pressure exceeds the 10 millimeter of mercury, and normally we augment the arterial pressure to like the mean arterial pressure should be more than 85. And intraoperative monitoring of the lower extremity, there is somatosensor evoke potential or motor evoke potential. Post-operative neurological assessment should be done by serial neurological examination, and later on I will discuss this with the neuroprotection. I'm not going details the arterial supply of the spinal cord, because this is the key factor why we should monitor either the SSAP or the MEP to monitor whether the spinal cord ischemia is going or not. But lower extremity weakness by spinal cord ischemia, paraplegia, there is division of 0, 1, 2 or paraparesis. Now, strategy to prevent this immediate onset paraplegia. There are two types of problem. One is just immediate, one is delayed. Now, what are the strategy to prevent the just immediate onset paraplegia? First, the mild systemic hypothermia should be maintained. Lumbar cerebrospinal fluid drainage when the CSF pressure goes above 10 millimeter of mercury. Selective spinal cord cooling, not experiences not much. Distal aortic perfusion should be maintained. Minimize the ischemic time. Segmental aortic reconstruction, intercostal artery preservation, and pharmacological neuroprotection. Intraoperative motor or somatosecondary evoked potential monitoring should be done, or arterial pressure augmentation. Now, delayed onset spinal cord ischemia. What are the prevention and treatment of this delayed onset spinal cord ischemia? Maintain the mean arterial pressure more than 85. Serial neurological assessment for lower extremity weakness or sensory loss. Immediate treatment to augment the spinal cord perfusion pressure. Arterial pressure augmentation with pressure pressure therapy, important. Lumbar cerebrospinal fluid drainage and prevent hypertension. Now, lumbar cerebrospinal fluid drainage, class 1 recommendation. Level of evidence B, improves the spinal cord perfusion pressure. It counters the increased CSF pressure caused by the aortic cross-clamping, reperfusion, increased CBP, and or spinal cord edema. It's performed by the insertion of a silicone elastometer ventriculostomy catheter via 14 gauge 2 needle at L3, L4 vertebral interspace. Drainage when spinal CSF pressure exceeds 10. Complication, neurological hematoma, catheter fracture, meningitis, intracranial hypertension, or spinal headache. And arterial pressure augmentation to increase this SCPP. The formula is the MAP, mean arterial pressure minus lumbar CSF pressure is the SCPP. So SCPP should be maintained greater than 70 millimeter mercury after TA repair. So that's why the MAP should be 80 to 100 millimeter mercury. Spinal cord ischemia involves thoracolumbar cord, which is accompanied by the significant vasodilated shock. So during coming of bypass, the vasopressors like norepinephrine, vasopressin, we should keep ready. High dose vasopressor therapy like norepinephrine, phenylephrine, epinephrine, and or vasopressin should be there. Theoretical hypertension must be weighted against risk, that is arterial bleeding. Intraoperative neurophysiological monitoring. Honestly speaking, we don't monitor this SSP or MAP, but the SSP or MAP is recommended to allow immediate intraoperative interventions such as intercostal artery implantation or relative arterial hypertension or CSF drainage. This is class 2B recommendation. SSP monitors either posterior and MAP monitors the anterior spinal column integrity. SSP monitoring is performed by applying electrical stimulus to the peripheral nerve and recording the evoked potential. MOP, they paired stimuli to scalp and recording the evoked potential generated in the anterior tibialis muscle. So latest thoracic aortic disease guideline says SSP alone suffice for clinical purpose. MAP does not add significantly to the clinical management. Spinal cord hypothermia, not done too much, not done very often. Tropical spinal cord hypothermia with cold saline epidural infusion as a part of multiple spinal protection protocol. Epidural cooling as adjunctive technique, that is a class 2B recommendation. So pharmacological protection of spinal cord like brain, that is high dose systemic glucocorticoid, mannitol, intrathecal papaverine, or anesthetic agent, that is class 2B recommendation, or lignocaine, naloxone, magnesium sulfate. But the application in clinical practice is very limited. So anesthetic management for thoraco-endovascular aortic repair. This is a new approach where the mortality in the thoraco-abdominal aortic aneurysm, the mortality is very high. So the people, now they are coming with a new approach with the endovascular repair. So additional concern in this particular approach is spinal cord ischemia and the stroke. If the spinal cord monitoring is planned, that is either SSP or MAP, the anesthetic technique must be designed not to interfere with their signal quality. This factor for the stroke, history of the prior stroke, very important. We have to take note of this prior stroke, mobile aortic arch atheroma, or the TFVR or proximal or entire descending thoracic aorta. This factor for the spinal cord ischemia, the perioperative hypotension, prior abdominal or descending thoracic aortic procedure, and that compromised spinal collateral arterial network, and the coverage of the entire descending thoracic aorta, that is significant loss of intercostal artery. So indication of the CSL lamina drainage in the TFVR, that is planned extensive coverage of the descending thoracic aorta, history of prior abdominal or descending thoracic aorta procedures, post-operative parapedesis or paraplegia despite relative hypertension. And lumbar CSF drainage is strongly recommended for spinal cord protection strategy for TE fever in patients with identified risk factor. That is a class 1 indication. Now, aortic dysfunction, I am not going in details. There is classification, DEBIKA classification, 1, 2, 3, 3A, 3B, standard classification. These are the pictures.
Dr. Chandan, sorry to interrupt. Your time is nearly over.
Just
So
I'll take. Yeah. So I'm just going to straight to this our one video. Recently we have done one this evita open plus chain graft system technique. Okay, it is a long video like tool, but I am not going in details. Just I want to say just one thing. This Samom Virod Singh is 47 years from Manipur, presented in our hospital with a history of chest pain 2 weeks back. I mean, just 4 weeks back. We prepared this presentation 2 weeks back. And he was later diagnosed with DBK type 3 dissection, that is Stanford type A, with a retrograde extension to the ascending aorta and the antegrade extension till celiac trunk, where the celiac trunk was arising from the false lumen. The aortic valve were spared with no AI and the coronaries were normal. So frozen elephant trunk procedure was planned and with the evita open plus chain graft. Just I'm giving just a view of the whole procedure. This is a stented, and this is the upper part is the graft one. Now, how we did the whole procedure, I'm not going details, but just see this part. False lumen and the true lumen. Stain going through this guide wire, and gradually we inflating the whole thing. Stains are getting inflated. So when the stain is inside, we suture the stain with the false and the true lumen, so there is no gap. Now we pull the vascular graft that is which was everted. Now we pull the whole thing. Now you cut the upper part and the island technique. We put that all the arch vessels. Okay. So this is in basic. So the final result, this is the final result. And this is the post-op CT aortogram. Patient had a smooth postoperative days, and we all found drops within day 3 and good spiral and effort and no complication. He was discharged on POD 8. So in this patient, we monitored the NIRS. You show the whole period. The right, it was showing the 73, and from the left it is 85, which is above normal. And in another patient, we observed these during the operation. It is the NIRS monitor, and we observed the decreasing part in the right part. So we asked, because there was some problem in the selective anterior cerebral perfusion in the aortic artery. So we asked surgeon to look into the problem. So later on, he managed the whole thing, and gradually we came up with the NIRS of more than 55. So thank you for patient hearing.
Thank you, Dr. You have to unshare your screen, please.
Yeah.
Thank you for that elaborate discussion. I hope, especially for the students and the rest of us it makes things a bit more clear regarding neuroprotection and the aorta. So for the next topic, as we all know, the COVID-19 pandemic situation is growing graver by the day, with the second wave knocking at the door. Compared to SARS-CoV and the Middle East respiratory syndrome, patients with COVID-19 are much more likely to experience cardiovascular complications, which raises the question as to which therapies would be most effective in cardiogenic shock secondary to COVID-19. Compared to the oft-used veno-venous ECMO in refractory hypoxia in COVID patients, veno-arterial ECMO use has only been reported in 4% of all COVID patients requiring ECMO, and the benefit remains unclear. This leads us to the next topic of discussion. Should veno-arterial ECMO be considered in COVID-19 patients? And it is an ongoing debate. For the same, in order to deliver the same topic, I would request Dr. DIPANJAN Chatterjee, who is a senior consultant cardiac anesthesia in Medica Superspeciality Hospital, to deliver the topic. Over to Dr. DIPANJAN Chatterjee.
Am I audible?
Yes, you are.
Yeah, thanks. Thank you, Shomi, to give this wonderful opportunity. And it is quite timely that we are back again with ECMO in COVID. COVID is again raging. The second wave is hitting us hard. Most of our hospital beds and everywhere else is ICU beds are almost full. And COVID ECMOs are again going up. So today we will be discussing a little about the VA ECMO in COVID-19. It's quite rare because mostly we have been used to listen or we know that COVID affects the lungs primarily, and most of these patients, they will be needing veno-venous ECMO for respiratory support. But where do we actually need a cardiovascular support to in these patients? And what are the problems that we face? We will be discussing in the next few minutes. So, though it is primarily and affects the lungs, frequently extrapulmonary manifestations are also seen in COVID-19 patients. And in patients with underlying cardiovascular disease, there is increased risk of severe COVID infection and increased risk of death. Heart is affected by various mechanisms, can be because of the oxidative stress or due to hypoxia. There is inhibition of the RAS system that will be coming later. There is a severe cytokine storm. There is a severe inflammatory mechanism which affects the myocardium, as well as there is microvascular and endothelial damage. They all affect the heart and lead to either fulminant myocarditis or acute coronary injuries. It can be all this systemic inflammation cause acute kidney injury, myocarditis, acute coronary syndrome incidences go up in the COVID-19 patients. Many patients, they present not with respiratory symptoms, but with chest pain and MI. Their tropes are higher. They present with arrhythmias, as well as we very frequently know that they are prone to thromboembolic manifestations. The other important thing is that COVID-19 affects the endothelium also. So endothelium all over our body gets affected. There is dysfunctional endothelium leading to micro and macrovascular dysfunction. So all these lead to there is increased cardiovascular as well as other complications. Another thing is that COVID, this 19, the virus, the coronavirus, that attaches to the ACE2 receptors, which are found in our many of our tissues, mainly the lungs, endothelium, etc. So SEE2, they come within the cell. They are taken within the cell through the SEE2 inhibitors, and there is a down regulation of these SEE2 receptors. What is the action of the SEE2 receptor is that it converts the angiotensin 2 to angiotensin 1 to 7. So angiotensin 1 to 7 is protective, but angiotensin 2 is harmful to our systems. So there is increased cardiovascular diseases in these patients and increased lung injury. We find that almost 24% of the patients who are hospitalized with COVID-19, they have heart failure, and clinically shock can be identified in at least 9 to 17% of the patients. In patients who have history of hypertension, diabetes, etc., they are at increased risk of cardiovascular injury. And patients with cardiac injury, there is increased incidence of mechanical ventilation. There are more chances of mechanical ventilation, the severe ARDS, acute kidney injury, and other coagulation disorders. They increase the mortality of these patients. So what happens actually? Because of the severe ARDS, it's also associated with a increased afterload of the right ventricle. The right ventricle fails, and it is a common problem that patients who are being ventilated with a high PEEP, high airway pressure, the lungs are very stiff. There, the right ventricle fails to deliver adequate output, and these patients, they will end up in cardiogenic shock due to the ARDS, leading to the right ventricular afterload increase. And in these patients who present with respiratory failure, and if it is not assessed early and not treated early, they progress to increased circulatory failure and then leading to multi-organ dysfunction. So respiratory failure presentation, if not treated, or if it is progressively increasing in spite of all your efforts, then it leads to circulatory failure and multi-organ dysfunction. So what are the indication of VA ECMO? It's same as in any other patient in where the cardiac output is low in spite of you are giving adequate doses of vasopressors, inotropes, etc. So that is the indication, but you have to remember that it has to be initiated prior to any development of irreversible multi-organ failure, because once the multi-organ failure becomes irreversible, institution of ECMO after that will be detrimental, will not be helpful. The common indications are severe heart failure with severe myocarditis, RV dysfunction because of pulmonary emboli. There can be persistent malignant arrhythmias in these patients. Patients may present with MI, and there are situations where the patient has been put on VV ECMO, and then the patient develops cardiopulmonary dysfunction, and we have to then convert into a VA ECMO or VAV ECMO that will come later. So you have put the patient on ventilator, patient not improving, put him on the venovenous ECMO, still the patient is having cardiovascular collapse, go for VA ECMO. So you have to decide whether you are going for a VV ECMO or a VA ECMO. Both has its own benefits. VV ECMO will support only the lungs, but in patients with RV dysfunction, if you increase the oxygenation, reduce the carbon dioxide, it helps to reduce the load on the right side of the heart. Also, the airway pressures will come down because of the reduced ventilatory support. VA ECMO will be supporting both the lungs and the heart. But many a times we will be needing the help of VAV ECMO, that is combination of both VV and VA ECMO, where we are giving the oxygenated blood both through the arterial route as well as to the venous route. Because why we are giving it? Because the lungs are stiff, it is not getting oxygen. The blood which is passing through the lungs to the left ventricle is deoxygenated, and if that heart is ejecting the blood, that deoxygenated blood will be going to the proximal branches, that is the coronaries as well as the cerebral circulation. So if we can give a little bit of oxygenated blood back through the right side of the heart, then the left ventricle will be getting the oxygenated blood, and the proximal branches will be getting the oxygenated blood. So the myocardium will be getting the oxygenated blood. So that is the benefit with the VAV ECMO, because that will give a better oxygenation to the patient as well as it improves in the cardiac function. This is a simple picture of the VAV ECMO, where in a VA ECMO we are taking blood from the vein, giving back to the arterial route. In VAV ECMO, there is one branch where it goes to the through the jugular back into the right side of the heart. Part of the return is to the right side of the heart. So I'll come to a few cases. A 57-year-old male patient with a bilateral whiteout chest on X-ray. He was initiated on VV ECMO within 24 hours of ventilation, was not improving. On 6th day, we found that he is having unstable hemodynamics in spite of higher supports. So this is the situation. You can see that even on 24 inspired pressure, only 50 ml of air is going within his lungs. So the compliance is too low. It's almost 2. So you can see that, is it visible? The left ventricle is contracting well. The right ventricle is dilated, grossly dilated. So in this patient, what we did was initially we put in 2 drainage cannulas to drain out the right ventricle, but that did not help. So we again put in a arterial cannula into the axillary, so that we converted into a VAV ECMO. You can see that the venous drainage is from the 2 femoral veins. The return is going, one is going to the arterial return to the axillary artery, and another is going to the jugular. So this is a video of the complete circuit. This is the deoxygenated blood which is getting drained. Going to the oxygenator, and then the return of the oxygenated blood is made. There is a Y. One is going to the arterial axillary artery, as well as the other is going to the jugular. So how much blood is going through each can be assessed by putting in a this flow meter. In the ultrasonic flow meter we can assess. The cardiac function improved. After 5 days on VAV ECMO, we converted the patient back to VV ECMO because the lungs were still stiff. The heart had improved. But on the 28th day of ECMO, we lost the patient because of systemic infections as well as non-improvement of the lungs. One more patient. This is an aortic aneurysm where we had to convert from VA to VAV conversion. Previous one was VV to VA. This is a 63-year-old male patient who presented with a impending rupture of this aneurysm. Just before the day of surgery, we found that his RT-PCR was positive. But since it was a life-saving surgery, we went ahead with it. This was the CT picture of this patient prior to the surgery. First stage, we did a deep branching. Then we put in a TIVAR. It is a covered stent to cover all the branches. And this is you can see the debranching thing. And we continued the patient on VA ECMO. But during this TIVAR process, there was a lot of blood loss, and we ended up with a bad lung. For that, we converted into a VAV ECMO for this patient. After 2 days of this TIVAR, we took the patient back to the OT, and we decompressed the aneurysm. The VAV ECMO was continued for 17 days. The lungs did not improve, as well as the patients had multi-organ dysfunction. So after 17 days, we couldn't continue the support any further. 2 more patients where we had futile attempts to VAV ECMO, and these are cases for which I am highlighting because where we should not go for the VAV ECMO in these patients. Because this was a 67-year-old male patient who was having COVID-19, was on ventilation. Initially, the relatives withheld consent for ECMO, but on 6th day of ventilation, the patient was severely hypoxic and the relatives gave a consent. But the patient already started to have unstable hemodynamics by that time. We initiated a VAV ECMO. Urine output dropped. Interleukins were sky high, more than 5,000. We did a cytosol dialysis, but the patient died after 48 hours. And another patient was 47-year-old male patient admitted in an outside hospital. And within 24 hours of ventilation, he was severely hypoxic and the call was given for ECMO. When we reached, we found that the pH was 6.85. It was a mixed respiratory and metabolic acidosis. And we retrieved the patient on VV ECMO, initially responded, but 6 hours post ECMO, the patient had a crashing hemodynamics with RV dysfunction, converted to VAV, but the patient did not survive. So these are the patients where we should avoid VAV conversion to VAV because that is not going to help. What is there in the ELSO registry? ELSO registry in the last 90 days, beyond 90 days back, there were 4,739 patients of confirmed COVID, and only 4% of them were on cardiac ECMO, that is VA ECMO, and 1% is on ECPR. What's there in the European studies? In the initial European studies, we find that VA ECMO was almost 9%. That is 1 year back on 21st March. There was only 9% VA ECMO. But in the end of the first phase, we can see that it had come down to 5% only. What happened in the second wave till March this year is again 4%. And the third wave that has started there, it's again 4% only. What it has been also found that what mode we are starting, VA or VV, if the patient is on VA, there is increased risk of death. The odds ratio for death is more if the patient is on VA or VAV rather than VV. Survival is again low because this was a study where around 135 patients were seen, and of them 122 were VV, 10 were VA. Survival of the 122, 60 patients survived. On only of the 10 VA patients, only 2 patients survive. So survival is less in VA, mainly because it's a multifactorial disease, multi-system disease affecting many of the systems of the body, where the need for support is higher. They are more sicker. One important thing is that in this study we found that there were second and third runs of ECMO. So many a times we fail to recognize this, but we should not give up on the patients when they are going down. We can go for second or third runs of ECMO if needed to save the patient. There is one small data. This is not about VV or VA, but it has been found that if the initiation pH is less than 7.23, the mortality rate is high. If the age is less than 60 years, mortality is 68%, whereas compared to more than 7.23 pH, mortality is approximately 40%. In more than 60 years, mortality, if the pH is low, goes above 90%. So if the patient's pH is low and if the patient is having a metabolic component to that, which is increasing, if the patient is on multiple supports, then before going into cardiovascular support, we should think twice. So coming to the take-home message, COVID-19, though it's a multi-system disease, use of VA ECMO has to be individualized in each patient. The number of VA ECMOs is less, and its use has to be categorized in each patient. It does not help in severe cytokine storm or in patients with severe multi-organ dysfunction. If the patient is having a severe cytokine storm, in spite of going on VA ECMO, we will not be able to save the patient many of the times. It may be useful in patients with cardiomyopathy with LV dysfunction, and it is definitely useful in patients who are having pulmonary embolism with associated RV dysfunction. Though the outcome is worse than VV, still, if you feel that the patient can survive, you can go ahead with VA ECMO or VAV ECMO, as it supports both the lungs and the heart. And in patients with higher age with cardiovascular disease, then the chances of survival are less. Thank you.
Thank you, Dr. DIPANJAN, for throwing light on this debatable topic. Thank you. If there are any questions from the audience, we can take in questions for over the next 1 minute. Any audience question?
Hello.
Hello.
Hello. Yeah.
I just
Yes.
want to congratulate DIPANJAN and Arpan for their wonderful job on ECMO.
Thank you. Thank you. Arpan is also here.
Especially Arpan. Arpan is helping me a lot. I am doing many ECMO with the help of DIPANJAN and Arpan.
Boss, when are you giving the party for your patient going home?
I was planned party next month, but this second wave is preventing me to give you party.
Okay, fine.
So I would request the audience, rest of the audience, if you have any questions, we can take in questions or we'll move to the next topic. So I think there are no specific questions.
One
So,
question, can I put here?
Yes,
Yeah, please go ahead.
Yes, Dr. Dipanjan, a simple question from my side. In the VA ECMO that you have mentioned, can you please comment on the cannula sizes commonly that you have used in VAV and VA ECMOs?
So VA ECMO, if it is a peripheral cannulation, see, if it's an adult male, the drainage cannula, the venous cannula is usually 24 size. It's an adult male, 24. More than that, if it can be 20. If you have a Mackay cannulas, that they are odd numbers, so 25 size cannulas. The return in the arterial system, if you do a peripheral femoral arterial cannulation, then we usually use a 16 sized cannula, and we also in the same time we put in a distal femoral perfusion cannula to prevent any ischemia in the ipsilateral limb. And in V ECMO, the return of the oxygenated blood, it goes also to the jugular. So in the jugular, we usually use either 18 or 20 size cannula. So, and if it is a female, then also we try to keep the drainage cannula size higher. Either 22, 24 size cannula at least has to be used, because the main thing is that in VA or VAV, the flow depends on the how much is the preload and how much is the size of the drainage cannula. If the drainage cannula is small, then it is a very big problem to maintain an adequate flow to the circulation.
And the return cannula sizes are 16 and
16 or 18
okay,
at the
okay,
most.
okay.
At the most, 16 is the usual standard size for our Indian Eastern Indian population.
Okay, okay. Thank you so much.
Thank you, Dr. Dipanjan. So the next topic, we'll move to the next topic, which is echo in the COVID era. Again, a very apt topic given the rising pandemic situation. So to deliver the same, I would request Dr. DEBIKA CHATTERJEE, who is a senior consultant and the HOD, Department of Noninvasive Cardiology, NH RTIICS Kolkata, to deliver the same. I would invite Dr. DEBIKA CHATTERJEE to take over from here. Thank you.
Thank you, Shomi. It's my pleasure to deliver this lecture. Thank you very much. So it's a very common topic in the era of COVID infection, and with the rapid rise of numbers of patients in the second wave, the world is again in the throes of pandemic. There is a devastating loss of human life, and this COVID infection has not only jeopardized our world's economy, it has also created disruption in our routine medical practice. However, a viral infection cannot cripple the operation of essential healthcare service. And echocardiography being an essential healthcare service, we need to provide safe and effective care for our cardiovascular patients. Needless to say that all necessary precautions and safety measures are to be provided to each and every member of the imaging team. If conducted in the usual way, which you used to do in the pre-COVID era, echo is such a test or such an investigation where both the patient as well as the doctor or sonologist are exposed to a high risk of infection because of close proximity to the face with face-to-face contact. So, and COVID-19 being such contagious disease, this cannot be continued. So we have adopted certain temporary measures with a total paradigm shift, the way we are doing echocardiography in the pre-COVID era and the post-COVID era. We need to protect the patient. We need to protect the doctor or the sonologist, as well as we need to protect the machine to prevent the transmission of infection. And by doing all these temporary protective measures, we are balancing ourselves with risk of infection by doing echocardiography to the inadequate patient's care by not doing echocardiography. No doubt we are facing challenges, constraints, but we know at the end of the day that it's the human spirit which prevails. So we are going to win the race. In the COVID era, we do the echocardiography for cardiovascular assessment of both non-COVID patient and COVID patient. COVID patients may be a suspected case, a confirmed case, or a recovering from the COVID infection. Whichever group the patient belongs to, the patient may be with or without pre-existing cardiovascular disease. We must remember that. And we face these patients while doing echocardiography in the echo lab, in the emergency room, in CCU, ITU, triage, ward, cath lab, as well as in the OT. But we must remember that a large number of patients of COVID infection remain asymptomatic, but still they transmit the virus to everybody. So that is why, irrespective of COVID status, COVID result status, all patients are to be considered as potentially positive while doing echocardiography. Now, in the initial phase of pandemic in the last year, echocardiography was done only in the urgent and emergent cases. We used to say it's essential imaging. All elective and non-essential imaging were deferred. And as a result of this essential imaging, cardiovascular imaging was reduced by around 50 to 90%. So over a period of last few months, it was found that this essential imaging has resulted in massive reduction in number, and which is very detrimental. Also, a lot of financial implication is there. We are running loss of revenues. So over a period of this last 1 year, there is a change in concept. Now the concept is that we will try to keep the numbers same by creating an environment of lower infective risk. And this environment of lower infective risk means that we need to provide safety precautions to safeguard each and every member of imaging team, the patient, as well as the equipment. And in a country like India, that safety measures, we must remember that safety measures should be innovative, cost-effective, and less time-consuming, because we deal with a huge number of patients. While providing the safety measures, we must not forget about the vulnerable members of our imaging team. Those who are over 60 years, immunocompromised, comorbid, or pregnant ladies should avoid contact with suspected or confirmed cases of COVID-19 infection, because they are very prone to develop the infection as well as to develop the negative consequences of COVID-19 infection. That is why they should avoid the contact with COVID patients. Statements on the safety measures while doing echocardiography has been given by various societies and organizations all over the world, like American Society of Echocardiography, then Cardiological Society of India, American College of Cardiology, European Association of Cardiovascular Imaging. Now, we must not forget that situation is dynamic, so the recommendations also are subject to change. So for the equipment care is concerned to prevent the transmission of infection, it's very crucial. We should cover the machine and the probe with disposable transparent plastic sheets. We should wipe probe surface with sanitizer after each and every procedure. There should be dedicated machine for COVID positive ward or ITU. And at the end of the day, we should discard all the plastic covers, should wipe the external area of the machine from top to bottom with regular sanitizer, and also after every visit to ITU, CCU, triage, or cath lab and the OT. But we must not forget that this cleaning of the equipment depends on the institutional policy also. So it's adopted as per the institutional standards. Now, when we cover the machine with the plastic sheets, we face various challenges. Because of this cover, the movement of the trackball becomes a bit troublesome. And due to the cover on the probe surface, the image quality becomes suboptimal. So we must remember that with these covers, protective covers, we always balance between the benefit and compromises. Now, when the question of this benefit and compromise comes, now again, a very, very important thing to remember, the duration of scanning. See, our main goal is to limit the time of exposure to infection. So the duration of scanning should be very short. So there are certain measures which we can take to reduce the timing of the scanning, like we can check the medical records in advance. We can do the offline measurements. Nowadays, in all the machines, the facility is there. And we need to do limited and focused study with the diagnostic views. Like it should be like point of care ultrasound, mainly to see the systolic function of LV, RV, presence of thrombus, presence of signs of pulmonary thromboembolism or pericardial effusion. Again, though the procedure is quick, but we should not forget that we should not compromise with accuracy, because otherwise we'll have to come back again to the patient for additional images. We should not compromise with the accuracy. And when all these questions of accuracy, quick procedure comes, now the question is, who will perform the scanning? We know that experienced echocardiographer can only do the quick procedure without compromising accuracy. Now again, the experienced echocardiographers often falls in this group, over 60 years, immunocompromised, comorbid, or maybe pregnant ladies. So ideally, a trained young cardiologist who is without comorbidity should do the echocardiography. The senior members of the echo team can always have a look at the recorded images. Now, while providing the precautions to the healthcare personnel, we know that there are two types of precautions. One is the droplet infection, another is airborne infection. Now, when we do the transthoracic echo or dobutamine stress echo in the echo lab or ward or in the emergency room, we need to provide droplet precaution. But the same procedure when done in the ITU, ICU, OT or cath lab, where there is a environment of invasive ventilation. So in these areas, if we do transthoracic or dobutamine stress echo, we need to provide airborne precaution. And for transesophageal echo, it's always the airborne precaution. Now, we must remember that personal protection equipment depends on the institutional policy and resources. Some of the institutions divide the patients, provide the PPE depending on whether it's a non-suspected or minimal chance of infection, or suspected infection or moderate chance, and the high risk means the confirmed cases. And some of the institutions, again, they treat the suspected and confirmed cases similarly. Now, in our lab and in our institutions, these are the personal protective equipment which we use for droplet precaution. We wear gloves, sometimes if needed, double gloves, isolation gown, N95 mask, and surgical cap for echo lab and the ward. And we add double gloves, N95 plus surgical mask, face shield, and shoe cover for the airborne precaution when we do the transesophageal echo or transthoracic in the areas where there is a chance of invasive ventilation and aerosol producing procedures. Now the question is whether transesophageal echo can be done in the COVID era, because it is an aerosol generating procedure and there is a high risk of virus transmission and contamination. But we know that transesophageal echo is often reliable imaging in certain situations, especially in before the cardiovascular surgeries. So the present recommendation for transesophageal echo is that we should perform it if there is a favorable risk to benefit ratio. So the indication should be very proper. And our negative COVID-19 test result must be there within, which is done within 24 to 72 hours. And in the interim period, patient should be quarantined. But we must not forget that sensitivity of COVID test is only 80 to 85%. So we always should wear appropriate PPE during the transesophageal echo. And other than the basic protective measures like frequent meticulous hand washing, avoid close face-to-face contact with the patient, must wear a mask, and bare minimum number of personnel should be present. And during transesophageal echo, this cannot be maintained. Patient cannot wear a mask. And we also need to sanitize the surrounding like patient's bed, desktop, chairs, phones, doorknobs, etc. So maintaining all these standards, now let us go to the common cardiovascular manifestations in the COVID-19 infection. Now, initially it was thought that COVID-19 involves only the respiratory system, but over the last 1 year, we have noticed that its complications goes beyond lung, and it not only involves the heart, it also involves the kidney, brain, etc. Now, it can involve the heart directly or indirectly, causing acute myocarditis, acute pericarditis. Even there may be acute coronary syndrome, heart failure, pulmonary thromboembolism, different types of arrhythmias, and also we face sometimes the adverse cardiac effects of the medications. Now, we must remember that the patients with pre-existing cardiovascular disease are more prone to develop all these complications, and these complications may occur even without signs and symptoms of respiratory symptoms like running nose, fever, pneumonia, etc. So we should be very careful. Now, let us start with myocarditis. This is the commonest cardiovascular complication of COVID-19 infection, with the incidence varying between 7 to 28%. And it is a strong negative prognostic marker. Around 7% of COVID deaths are related to myocarditis. The signs usually appear 8 to 14 days after the onset of COVID symptom, and various mechanisms are said to be responsible for development of myocarditis. It might be a direct injury by binding of the virus to ACE2 and altering the signaling pathway of ACE2, causing the injury to the lung and the heart. Microvascular injury of the myocardial vasculature by microthrombi is another possibility. And cytokine storm and sympathetic surge during COVID infection may cause stress cardiomyopathy resulting in myocarditis, or it might be a case of acute coronary syndrome and MI, and also might be due to systemic hyperinflammatory response. Now, whatever may be the mechanism responsible for myocarditis, it is manifested by elevation of high sensitivity cardiac troponin. Let me show this case, who is a 60 years old male, had a history of hypertension and hyperlipidemia. He was complaining of chest discomfort for last 2 days. Typical cardiac type of chest discomfort for 2 days, but he didn't have a history of fever or respiratory symptoms. He never had exposure to COVID infection. And on examination, we found that patient was afebrile, ECG showed diffuse ST elevation, and cardiac enzyme was elevated. Chest X-ray was showing normal heart and the lungs. COVID test was sent, but we didn't receive the result. It was in the beginning of the pandemic last year. Patient was repeatedly complaining of chest discomfort, and echocardiography showed concentric LVH with global hypokinesia, ejection fraction of 30%. RV was dilated, hypokinetic free valves were normal, but there was a small P. So clinically, and the diagnosis and also the ECG showed diffuse changes. So a diagnosis of STEMI was made. Though the COVID test was sent, but as it was in the beginning, so because the patient started complaining, the patient was taken for coronary angiogram, where we found that he was having a minor coronary artery disease. There was no obstructive lesion. And later on, COVID test turned out to be positive, and the repeat echo on 10th day showed that LV ejection fraction improved to 50% from 30%, and wall thickness also was reduced. Now, a similar case was reported in circulation where chest pain with diffuse ST elevation was mimicking STEMI. So what the lesson we learned from this case? That COVID test is a must, even in absence of fever or respiratory system, even though patient complains of chest pain, because we expose the entire team to the COVID positive case without much precaution. And also we must remember that elevated troponin due to acute myocarditis in COVID-19 infection can mimic the STEMI. Now, if we learn this lesson and try to use this lesson learned in every case, we'll be in problem. Here is another patient who is 55 years old woman with hypertension, presented with history of shortness of breath, dull chest pain, fever for 10 days. She had passed few episodes of similar shortness of breath with dull chest pain in the past. And on examination, ECG was showing new onset LBBB, cardiac enzyme was elevated, and transthoracic echo showed LV systolic dysfunction with ejection fraction of 35%. And COVID test, this time we waited for the COVID result, and it was found to be positive. Now, how to proceed? We have learned that in a COVID patient, elevated cardiac enzyme with such vague history might be due to myocarditis, not due to STEMI. So now the question is whether we should proceed for coronary angiogram with additional risk of exposure to COVID-19 infection. But since the findings were suggestive and he gave similar history of chest pain in the past, we did the angiogram, and it was found that the patient had 99% stenosis in the mid LAD. So again, we learned a lesson. A similar patient was also reported in JAC last year, where a misdiagnosis was done in a COVID-19 patient, though it was a true STEMI, but it was missed. So we learn again a lesson that when zebras are everywhere, we shouldn't forget the horses. So raised troponin is not always due to acute myocarditis in COVID patient. It might be due to ACS, which is an important cause of myocardial injury in COVID patient. The here is a patient. You see, this is the LAD area, which is akinetic, and epidemiologic studies have shown that viral infections, many viral infections, are associated with an increased risk of coronary events, including this the COVID-19 virus, because of the cytokine and inflammatory mediators. These substances can lead to the localized arterial inflammation of the coronary arteries. So the plaques, which were not limiting the flow in a normal condition in the same patient, can now produce ischemic injury because of this arterial inflammation. And we also know that in COVID-19 infection, there is a hypercoagulable state, abnormal activation of coagulation takes place, along with abnormal fibrinolytic system, and resulting in formation of thrombus. As you can see here, This was a patient who had a LAD infarction. Along with that, there is a large thrombus at the apex. Now, because of this abnormal activation of coagulation system, there's a chance of formation of thrombus in the veins, leading to a life-threatening complication in the COVID patients, that is pulmonary embolism. Now, this is the patients who present with pleuritic chest pain, shortness of breath with fall of BP, and the clinical deterioration results from the right-sided heart failure. And massive pulmonary thromboembolism may result in hemodynamic collapse, hypoxia, and death. Now, and that patient who presented to us with pulmonary thromboembolism, we got dilated right ventricle. If you look at the RV free wall, it's showing akinesia, so systolic dysfunction. And normally, we know that RV is around 1/3 of the LV, whereas it is almost equal in size, maybe slightly larger than the LV. And normally, apex is formed by the LV, but in this case, both are taking part in formation of the apex. If you look at the IVS, it's flattened, LV function is preserved, and IVC was dilated. And a peripheral vascular Doppler showed multiple venous thrombus, and it's CT scan of the chest, which confirmed the diagnosis. Now, this type of RV dilatation with or without systolic dysfunction is seen in COVID patients with a high prevalence. The literatures have shown that in many cases, there is RV dilatation. And this finding of RV dilatation with or without systolic dysfunction is associated with early mortality, and it's independent of standard clinical biomarker risk stratification. Now, causes of this RV dilatation with or without systolic dysfunction might be other than pulmonary thromboembolism. It might be due to hypoxic pulmonary vasoconstriction, or ventilator-induced lung injury, or might be due to direct myocardial injury in the RV myocardium. Now, a multi-center prospective observational cohort study was conducted recently, which is going to be published in American Society of Echocardiography journal. This study was conducted in around 200 cases over the 18 years of age, and they followed up the case for 3 months. So what they found that in a large number of patients, there was RV abnormality, either in the form of dilatation with normal RV systolic function, or it might be a normal RV size with RV systolic dysfunction, or dilated RV with RV systolic dysfunction. And in follow-up, they found that no improvement took place in the patients who had normal-sized RV with RV systolic dysfunction. Whereas in the other two groups, there was a significant reduction in the number, so indicating that they had improvement in the RV systolic function. Now, because of this thrombus formation, we also may get in other cases because of this hypercoagulable state. Like one case was reported, one case of LV thrombus was reported in Takotsubo cardiomyopathy, and it came in DHca last year, who is a 74-year-old male, hypertensive, diabetic, dyslipidemic, presented with fever, shortness of breath, cough, chest pain for 5 days. COVID was positive. ECG showed ST elevation, which was suggestive of acute myocardial infarction. Cardiac enzymes were elevated. Coronary angiogram was normal. And look at the transthoracic echo. LV was dilated, showing akinesia of mid and the apical segments, whereas hyperkinesia of the base, which is a typical finding of Takotsubo cardiomyopathy. LV ejection fraction was 30%, and there were 2 large thrombi at the LV apex. whereas echo on 14th day showed total resolution of the thrombi along with the improvement of the ejection fraction to 57%. Earlier it was 30%, and then on 14th day it went up to 57%. Pericardial involvement also occurs usually we get in many of the viral infections, but we get a very small pericardial effusion with benign course, and patient may present with chest pain. Only one case of cardiac tamponade was reported, which I am going to show. Usually we get a small pericardial effusion, see anteriorly and posteriorly in the parasternal long axis, also all around the heart, and here this is the subcostal view, this is liver. A small pericardial effusion is present anterior to the RV as well as on the lateral aspect of the heart. Now, this case of pericardial effusion with tamponade was reported in JAC. This is the only case of large hemorrhagic PE was reported in a COVID patient who was 67 years old lady, a known case of non-ischemic cardiomyopathy with ejection fraction of 40%. She was not on antiplatelet or anticoagulant, no history of malignancy or coagulopathy, and then presented with mild cough, mild shortness of breath for last 3 days. Chest X-ray was normal, COVID was positive, and transthoracic echo showed global hypokinesia with LV ejection fraction of 40%, but no pericardial effusion. Then patient suddenly deteriorated after 1 week. She had orthopnea, and then on physical examination, heart rate was high, 122 beats per minute. Respiration rate was 24 per minute, and the heart sounds were distant. Chest X-ray showed cardiomegaly. Enzymes were normal. And transthoracic echo this time showed a large pericardial effusion all around the heart with signs of impending cardiac tamponade. And ejection fraction was 40%. There was no RWMA, and IVC was dilated but collapsing. So pericardiocentesis was done, and it yielded around 800 ml of exudative bloody fluid. So this was the only case of large hemorrhagic pericardial effusion with tamponade which was reported. Many cases presented with cardiogenic shock, as Dr. DIPANJAN has already shown nicely all the cases, even in this which were rescued by ECMO throughout the world, and a very good number of cases improved in Kolkata also. Dr. DIPANJAN and his team did a fantastic job, so I'm not going to explain that. And this patient, which was reported, was 38 years old, diabetic, history of cough, shortness of breath for 2 days. In chest X-ray, there was pulmonary opacity, COVID was positive. Transthoracic echo initially was normal with no RWMA, ejection fraction 60%. Then patient suddenly had SVT and deteriorated, had a cardiac arrest, and repeat echo now showing ejection fraction of only 20 to 25%. RV was normal in size, and but then there was reduced systolic function. This patient was rescued with ECMO. So in short, these are the common cardiovascular manifestations of COVID-19 infection. And I have shown you how crucial echocardiography is in identifying all these complications. So we are struggling, we are getting challenged while fighting with the battle, fighting the battle with COVID-19 infection. But we have realized how important echocardiography is in identifying these complications, also in taking the decision regarding the management. So it's a challenge for the imaging team, and we should never lower our guard while doing echocardiography, because high chance of getting the infection as we work face to face And also during T, there is an aerosol generation. So we should always adhere to the best protective protocols while doing echo in the echo lab or in the ICU, ITU, triage, and especially while doing transesophageal echocardiography because it is an aerosol generating procedure. Thank you.
Thank you, madam, for that excellent deliberation. Thanks a lot for sharing your knowledge and experience with us. If there is any audience question, which we can take 1 or 2 audience questions. I think nobody has any questions. So, thank you. Thank you, madam. So we have come to the end of our scientific program today. Thanks to all the speakers and participants for joining in. Hope it has been an enriching 90 minutes with the lectures adding to our collective practical knowledge. Thank you all till we meet again for our next annual conference. Over to Dr. Ashok Verma to conclude.
My sincere thanks to all the members for attending the webinar. Thanks to our faculty, Dr. DEBIKA Madam, Dr. DIPANJAN and Dr. CHANDAN. Thank you, Dr. Shomi, for moderating and making the program successful. Thank you all. Thank you very much.